I'm Susan Green. I'm the editor of the Colorado Independent, and this is our, I'd like to introduce you to Chris Blumenstein, social worker, whistleblower, and righteous superhero, who we're awarding our first annual Whistleblower Award tonight to. This is, when we planned this event, we had hoped that Chris's client, Roger Holmes, who this story is mostly about, would be here to tell his story, because it's a pretty unbelievable story. And that looked like kind of maybe a possibility a month ago. And if you could tell us what's gone on since, that'd be great.
Well, I think the first thing I'd like to say is to thank you, Susan, and the Colorado Independent, and everybody for being here. It's an odd time to be doing this, not odd in that it's been our choice, but just sort of circumstance. Because Roger's health is horrible. Those of you who are familiar with his story will know that he's been in very poor health since his treatment went wrong. And he had an infection that ran rampant through his body starting last week, and has now landed him in the ICU at St. Mary's Hospital with minimal neurological response right now. He's been on a respirator for a week, and he's been battling sepsis and low blood pressure and those things that go along with serious infection and circulatory systems for folks who have badly damaged health. And this morning I've been in Grand Junction spending time with him. Of course, he's not aware, at least in any sense that we're familiar with, of people being with him, although those of us who've been in that circumstance like to think that people are aware and believe that. His son is also there. He's come out from Salt Lake City, which is very good, and his daughter-in-law. And this morning the doctor was talking about end-of-life decisions. Do we sustain these heroic life support measures, or do we let him go because he was not responding well to the heroic measures to date? I had a text from JJ, his son, just a while ago saying today was a slightly hopeful day, that he's doing better with his oxygen levels, and that he had responded to some commands to try and squeeze a hand and things of that nature. So we have hope, but it's been very, very grim, and every hour brings it's just an hour-by-hour situation. And so the reason Susan was very, when this developed, Susan was very considerate and kind and said, "Chris, do you want to reschedule this? Should we do this at another time?" And without hesitation, both myself and Jenny Davies Schley, who we would tell, believe me.
Jenny, you should stand up.
I would be, Jenny Davies Schley is the principal of Progressive Promotions and a progressive activist in the Denver and Colorado communities. And I joke with Jenny that without having found her, I'd be wandering the streets, mumbling to myself about not being able to really break through and getting Roger some attention. So thank you, Jenny. I said to Susan, let's go forward, because this has always been, for Roger, about much more than just himself. He really embraces the concept that this is an opportunity for him to be of service, and that for his story to mean things that are bigger than just himself. And we'll talk about some of the reasons that it is later, I'm sure. So that's why we've decided to continue, even in the face of such really devastating medical developments over the past week.
So we're going to try to take you through this story. Chris, can you talk about the Roger Holmes you met when you first took on his case, and the Roger Holmes, the way Roger was before April when he elected to have treatment for hepatitis C?
Yeah. Well, Susan asked me when we met over there, or on the phone at some point, would I have gone to these measures? Would I have taken every step that I could think of taking? And that's really, you sit here and you call the whistleblower, you've done this thing, and it's, it's not like that's what you set out to do. You just set out one day at a time to try and help somebody who's getting a raw deal. It's confusing. It's overwhelming. I've made so many mistakes. It's almost unbelievable the number of mistakes I've made. But what I've done is just kept plowing ahead. So, Susan asked me, would you have done this for someone that wasn't Roger? Because by then I'd already described who Roger was to her. And I sort of said...
I'm sorry to interrupt, but he was his social worker at the VA in Grand Junction, just to fill people in. Okay. I was a social worker in addictions and PTSD treatment in Seattle for 3 years, VA. And then for 2 years, I was a social worker and case manager in the homelessness and supportive housing program. So Roger was a formerly homeless veteran. And let me say one thing, which is I talk about Roger's history. I talk about his medical conditions, including some very intimate personal details, because he has asked me to do that as part of his campaign, which is about more than just helping himself. Very explicit. We have that conversation again and again. I would not be talking about this man's personal details or intimate health in the way that I do without his not only blessing but request. Yes, Chris, get out there, talk about me, talk about these things in order to help me and others. So I was for 2 years Roger Holmes' case manager and social worker in the VA supportive housing program and homelessness program. You might have also heard it referred to as HUD-VASH, because it is, in some of its funding mechanisms, a partnership between HUD, or the Housing and Urban Development, and the VA. Wonderful program. And I began that job in April of 2012, and one of my jobs was to be the case manager for a development in Grand Junction called St. Martin Place, which is a very prestigious and prominent development in the community. The governor came out when ground was broken and it was open, and there's pictures of Roger, talking. Roger was the very first formerly homeless veteran selected for the St. Martin Place community. And when I began work, he had been in his home for a year. So he had a history of homelessness, a history of alcoholism. He had rebuilt his life. He had gone through a very difficult 6-month-long addictions treatment program in Grand Junction, and had been stable in his housing and in his life and building his new life for already a year when I came on for this position, and was giving back as much or as more than anybody else in our HUD-VASH program. He would we all talk about people who are sick and people who have passed as, we gild them in gold, and so there's this inclination that when I'm talking about Roger, I'm gilding him in gold, but he's a golden man. He was. It's what makes this situation so mind blowing. He did everything right. He rebuilt his life. He was giving back to the community, 20 plus hours a week, volunteering for other homeless veterans and addicted veterans in the Salvation Army Addictions Program. He was playing drums in church. He was he is kind, humble, a man of few words but wise words. Much of his wisdom driven by his belief in the 12-step model of recovery and a power greater than himself, and being of service to others as the true meaning that we can find in life. So he was, and then I worked with him. We met as social work is very much about meeting as equals in any context. And having that not I'm an expert, but having that on the same plane kind of relationship with the client, and yet at the same time,
that was just very, very natural because I absorbed as much wisdom and sort of life wisdom from Roger as certainly he got any from me. I don't know. He's functional, active, special, and really uplifting. I think in our campaign on our website, we inspirational. I think I say, I took inspiration from him, and he gave to other veterans. So it makes what has happened and how he was treated all the more sort of unfair.
Can you tell me a little bit about his feelings about the VA and also your experience with the VA until Roger got sick?
Yeah. Well, I didn't set out to necessarily. I have veterans in my family, uncles, and I am not a veteran, and I had this sort of a generalist support of veterans in our society and in our country. So I didn't set out to have a mission as a social worker, which is a second career for me, or almost a third. But I went. This was a second career, and I went to graduate school in social work in Boise at Boise State University, and they had a wonderful internship at the Boise VA. And so that's where I got immersed in sort of working in the VA and working with veterans, and also getting just this extraordinary training from all of these incredible social workers and psychologists and addictions therapists and doctors and nurses that worked in the VA. I mean, it's the richest training environment one could have. And I loved it, and I loved working with veterans, and I kind of loved all the resources that we had in Boise. And so from there, I went on to Seattle for 3 years. I had a similarly positive experience, although being a PTSD therapist is hard. Being a trauma therapist is hard, and it takes a toll, and it took a toll on me personally and psychologically, such that that's why I decided to do this other job for a while and be a case manager. So, and then, and then Grand Junction was awesome. That was a great job, and there was something so rewarding about getting, being able to help a veteran who is homeless and struggling and see them go through the process of maybe establishing sobriety or some help for mental health, and then get into housing. And what a great day that is when somebody gets into housing. So it's one of the things that makes this sort of extraordinary. Is I've loved working in the VA personally. Now, having said that, I always say there's no such thing as the VA, in my opinion, because I work with 95% of just wonderful, committed, dedicated professionals in all sorts of healthcare and associated fields. The other 5% we don't need to talk about, because we all have that 5% in our professional lives. The difference in the VA is you can't get rid of them. You literally can't. I mean, I can tell you some stories about where those people get put who perhaps haven't performed at a very high level or an ethical level or something. You can't be fired, but management will find creative places to put them. But then there's the system of the VA and the management and administrative structures of the system. And that, in my experience, is what is so broken. So it's this weird and almost, at times it can almost border on the absurd experience of working with these wonderful, dedicated, talented professionals, caring, giving, but if the system feels dysfunctional, if the management structure feels dysfunctional, if there's layer upon layer upon layer of bureaucracy or outdated technology or staffing shortages. I mean, Roger's story is a big part of Roger's story is about staffing shortages. It creates all sort of weird interplay. And at times, as what happened with Roger, I think of it as pulling on a rope. If you have everybody who's pulling on a rope this direction, things move the way you want them to. But if you got a person pulling here and a person pulling here and a person pulling here, and those three ends of the rope are there's nobody on those three parts, then there's going to be lots of kinds of problems. And it's not because the people pulling on the ropes aren't trying real hard. It's because systemically there are flaws, big ones at times.
So Roger served in Vietnam. He had some troubles for years, and he was the first resident of this project, and really a success story.
Mm-hmm.
And can you just briefly just talk about how he felt about his having served in Vietnam and how he felt about the VA?
Yeah, well, Roger, I can't speak much to how he felt about serving in Vietnam, other than because it was hard.
But as his identity, it's part of his identity.
Uh-huh. Well, Roger was extremely proud of being a veteran, and you'd always see him with his U.S. Army cap on or his Vietnam veteran. I say was, and it's so disconcerting to me to hear me say that but I've seen him this past week, and he's not been there. And then the doctor was saying, it's so. Roger is very disconcerting to hear myself say that. Roger is very proud of his service and of being a veteran, and he always wears his hat. It's probably on some of the pictures. And he's such a proponent of the VA. I mean, up until this event, he was always talking about his gratitude toward the VA and for giving him his life back and giving him this housing and the supports that he had gotten from the VA. So Roger's experience up until this point was one of profound gratitude towards the Grand Junction VA, at least. I don't know about other VA experiences he had earlier in his life.
So he was doing well. He was in recovery. He was sponsoring other people through it. He's volunteering, and you said, got his life to a point of stability where he could think about his health more broadly. He had hepatitis C, like a lot of people and a lot of veterans.
Yeah.
And there are treatments that are elective. If he was walking around as a kind of healthy, active 64-year-old.
Yeah.
And then what happened? He was walking around not looking like that.
Yeah, those are pictures from after his release from the nursing home, his 2.5 month hospitalization. Roger's decision to enroll in this elective hepatitis C treatment was very much a consequence of having rebuilt his life. Those who are familiar with hepatitis C treatment, and particularly with interferon treatment, know that it can be accompanied, not only, it will certainly be accompanied by all sorts of physical illness and weakness, but is almost always accompanied by devastating depression, or frequently is accompanied by serious depression, or at least struggles with it. So, it's a really hard decision for a lot of people to make, whether to begin interferon treatment, especially recovering folks or folks who have struggled with depression in their life, because on the one hand they want to try and heal their liver, on the other hand they don't want to relapse on alcohol or struggle with depression or suicidality. So Roger's decision to elect to pursue this treatment was driven by some degradation in his liver health. He saw a primary care physician in April, and she said, your condition is progressing as one would expect. You've had it for 40 years, and you've been for however many years. You're sort of on this trajectory, and if you want to live this new life that you've built for yourself for as long and healthy a time as possible, and you do this treatment, then you get this trajectory. All things being equal, of course, which how do we know in our own lives that will be the case? So it was very much a decision about having the best quality of life that he could have for as long as he could have. There was no crisis. There was no crisis, I guess is what I would say. There had been no, he didn't look or act or feel any different. There was no real degradation in his health, other than that he'd been on this trajectory because he has hepatitis C, and that degrades the liver over time, and he wanted to be on this trajectory. The other factor is the advent of this new drug that I always mispronounce, sofosbuvir.
Say that again.
No. Which Roger's treatment, he opted for combination interferon and that other thing.
Supposed to be
As well as ribavirin, which is typically, we talk about in our webpage, 3-drug treatment. Ribavirin is typically a part of any of those treatments. So the great benefit of the sofosbuvir is that it takes the duration of the treatment and it radically condenses it. So whereas a typical interferon treatment could go 6 months, 9 months, a year. I've spoken with guys who went on for more than a year to kill this virus. It's a chemotherapy model in sort of a conceptual sense. The viruses are hard to kill. It's in your liver. We give you these really harsh, powerful drugs, and we're trying for this zone where if we're up here, we're not killing the virus, and if we're down here, we're killing the liver, and in interferon's case, the brain. And so you're looking for this zone where you're killing the virus but not the liver. But you're going to be sick. You're going to look and be sick as you're going through that treatment, just like in chemotherapy. So, the advent of this new drug, it radically condenses the amount of time required to go through treatment. And Roger's expectation is that his treatment would last for 3 months.
So this is not the type of treatment, it's not like prescribing aspirin or antibiotics. It requires someone monitoring a very delicate balance of a lot of very complicated and potentially super dangerous drugs. Can you tell us, he went on the treatment and what happened next? What went wrong?
I say that Roger's treatment was within expected parameters for the first 5 to 6 to 7 weeks, which means he was sick, but he was expected to be sick. That's what happens when you go through this treatment. He tells me in retrospect that he felt satisfied with the amount of support that he was getting through the hepatitis C program at the Grand Junction VA. But then, I describe it as a phenomenon, and I described it in the time as a phenomenon. We almost sort of went into a funnel or a warp. We got sucked into this event together. And I say together, I don't pretend that I went through what Roger went through, but I was witness to it. And I tried to help him within it as much as I could. In early June, his condition worsened. He developed complications. And anybody who's familiar with the course of care document that I wrote that's part of our comprehensive report, but the course of care document was submitted to the Hospital Safety Office on June 30th, and it kind of, hey, if you're interested in this, you can come along with me and Roger day by day and see everything that went wrong.
Everything. I mean, he chronicled it in a very meticulous way. Sorry.
So, he developed complications. It was apparent to me and to the hepatitis program pharmacist, which was the provider he was most frequently in contact with, that his cognitions, his memory, his attention, his concentration were degrading substantially. He was walking tentatively. And this is from, like I said, this is Roger in April. This is Roger sick, but expected sick. And then here is where we're starting to go in the first week and the second week of June. And he was walking tentatively. I had concerns about a fall. He was very, very weak. He was lethargic. He was losing weight. And he was having substantial distension or swelling of his belly and his lower extremities, as well as nosebleeds. So that was obviously of significant concern to both myself and to the pharmacist as we started observing this. And the first problem with that scenario right there is it shouldn't really be a pharmacist and a social worker who are discovering this about a patient. And then we, to put it succinctly, because I think Susan will have sort of follow-up questions, we found ourselves on or around June 9th to June 17th with this rapidly, obviously, common sense, deteriorating patient looking around for a doctor to treat him. who's supposed to be treating this guy? And maybe that's the next question, or maybe that's where.
Who?
Well, this
Makes
is
it so
not
easy.
this is not a story about a single person's shortcomings. It's a story about a lot of people's shortcomings and systemic shortcomings. But one of the people whose story is about shortcomings is the Grand Junction Hospital liver specialist. He was the person in whom Roger put his trust to begin this elective treatment and see him through this elective treatment. And for reasons that we hope and feel more confident every day will ultimately have to be answered by an OIG and possibly an FBI investigation, that person was not available from June 9th to July 1st. And so one of the analogies I use in Roger's circumstance is sort of Russian doll. It's problems nested within problems and nested within problems and nested within problems. And certainly one of the problems that this whole situation exists in is the context of the absence of a specialist care provider, the person with whom Roger enrolled in treatment. Now you'll hear that I'm using the singular, a liver specialist. I mean, that was the reality at Grand Junction VA. It's one of the smallest, if not the smallest, medical center in the VA. And I mean medical center because there's lots of community-based outpatient clinics that are smaller. But as far as something that calls itself a medical center, it's either the first or the second smallest. And so it had a singular liver specialist. A liver specialist can be an internist with significant liver disease treatment experience. It can be an infectious disease expert with the same. That's sort of the minimum. That's okay. It's not the greatest, but it's okay. The industry standard is a gastroenterologist, GI. Liver is part of the GI tract. And the gold standard, the blue standard, is a hepatologist. But those are few and far between. And it's probably not a realistic standard to expect a hepatologist to be available in a lot of VA hospitals. In fact, I think there's only one who works part-time in the Denver hospital. So the gastroenterologist is industry standard, but the appropriate kind of internist or infectious disease expert is also okay. And the Grand Junction VA liver specialist was an internist with extensive history of treating hepatitis C and liver disease, so that's okay. But that person was not available between June 9th and July 1st, and consequently there was nobody else. And so the reason that this is, and it's almost grim to kind of take pleasure in it, but because I am of an intellectual bent, it is fascinating to reflect at the dynamics that led to this, which have a lot to do with this being such a small hospital and the fact that the next level of physicians who made decisions about Roger's care in that period of deterioration are also management personnel, i.e. the director of medicine, the chief of medicine and the chief of staff. So these were both the doctors that were making a lot of the medical decisions about where Roger was going to be seen, but they were also sort of management personnel. And so the reason I'm mentioning that is that very quickly, because poor decisions were made, the entire hospital and the entire management structure and administrative structure of the hospital was involved directly in some of the very wrong decisions that were made with Roger's care. The first of which is the decision that we have this complex liver disease patient who's enrolled in specialist hepatitis C care in our hospital, and the doctor's not around, so what makes sense and what they should have done was refer him to St. Mary's Hospital in the community where there's 4 gastroenterologists and where we regularly refer patients who need specialist care not available at the VA, or have them seen at Grand Junction VA or Salt Lake City VA. And the single greatest thing that's come out of Roger's campaign to date, and the reason, no clear example of why we say it's about so much more than just Roger, is the fact, as was revealed in the Denver Post article, that the Grand Junction VA is no longer administering hepatitis C program, is no longer administering hepatitis C. They're sending those patients to Denver. So that's a wonderful change that's come as a consequence of Roger's tragedy, and is of benefit to all veterans in Western Colorado. So because that decision was made by the chief of medicine and or the chief of staff not to refer him out to specialist care in the absence of the VA specialist provider, that's when our down the rabbit hole kind of Alice in Wonderland crazy journey began within the Grand Junction VA, between all of these primary care clinics and emergency rooms and the nutritionists trying to figure it all out. And I think that kind of, in the interest of time, we probably can't, I could talk about that for hours because there's so many twists and turns. But I don't think there's any sort of clearer encapsulation of that phenomenon that on June 25th at about 4 p.m., when Roger was 12 hours away from being emergency hospitalized by ambulance from his home, and was about 24 hours away from overhearing staff that he might not survive the weekend, his last appointment was in a primary care clinic, which was not his primary care clinic, that was being administered by a nurse practitioner because that's the best staffing that the VA could provide at that point. It's not these people's fault. I don't, that's something maybe we can talk about separately. One of the things that's wrong here is that there's been all these providers required to practice beyond their appropriate scope of practice. And as I said in the KGNU article or interview, it's as unfair to them as it is to Roger. That's not true. I corrected myself then, and I'll correct it again, because nothing's as unfair as this has been to Roger. Only one person has had their life destroyed. But to get back to my point, at 4 p.m. on June 25th, 12 hours after this emergency hospitalization, with this guy that he looks like he's dying. I mean, we've all been around people probably at this point in life who, this guy looks like he's dying. We know that look. He was in a primary care appointment in a clinic other than his own with a nurse practitioner and the same poor, mistreated pharmacist who was left holding all the bag for this hepatitis clinic. And they were on the phone with a pharmacist at the San Francisco VA and a family practice doctor at St. Mary Hospital asking if someone could give them some advice on what to do with this guy's liver medication. You can imagine a doctor at St. Mary's Hospital getting a call from the VA going, we've got this guy you've never met before that we've had on interferon treatment, but we don't have any doctors. Do you have any ideas on what we should do? I mean, if I were to pick one slice of just the fundamental wrongness of the whole thing, that would be one of the top candidates, but unfortunately not the only one.
So the rabbit hole, can you give us some low points in the rabbit hole and talk about the hospice area that he ended up in, and just talk about the rabbit hole? What happened to Roger, and what did he know was happening?
He didn't know anything because his mind was gone. I mean, he was massively cognitively impaired by the time the second half of June was rolling around. He didn't have a clue what was going on. I don't know. I almost wouldn't know where to start, Susan, but I guess I can pick out some lowlights. I already mentioned one. Just the basic fact of us wheeling around this hospital, going from this place to that place, from that appointment we went to the ultrasound. They didn't know what was going on. We went to the ER. They didn't know what was going on. One of the minor points in my report, but I think it's a critical point, is that when Roger and I went to ultrasound after the appointment that I just mentioned for this emergency scan of his abdomen because he was so distended, Well, not just because of that, but because of whatever the nurse practitioner and the pharmacist and the family practice doctor and the pharmacist in San Francisco had decided. We went for this emergency ultrasound, and they didn't know what was going on. And then we went to the ER, referred to the ER. They didn't know what was going on. Roger was discharged home. I couldn't believe it, I have fantasies in retrospect. I blame myself for so many things. And, I have fantasies. We may have all had events in life that's like just of taking him to frickin' St. Mary's at that point and saying, can we get this guy a doctor? I'll pay, I'll pay. But the reality, and this may be absolving myself, but it's also the reality, maybe it's both, is that in a hospital, doctors tell you what's right and what's wrong. I mean, they tell you what makes sense and what doesn't make sense. So I couldn't believe that they released him from the ER that night, but, that's what they did. He was, the next call I got, 8 a.m., I got him home. If you read the report, that's where I had to kind of help him get to his door. He had to hold my arm to get to his door. And then first thing the next morning, I get a call, saying, well, can you go over there and call the ambulance? Because we think we should, bring him in. So it's never a good thing when you're hospitalized by ambulance from your home 12 hours after being released from the ER. And that was when the chief of staff and maybe the chief of medicine, some combination of those two, came in the next morning and saw that the mess maybe that the previous afternoon had looked like. So from there, Roger spent that weekend in maybe what was ICU or maybe wasn't ICU. I mean, spin may have already begun at the Grand Junction VA. There's a few rooms outside of the ICU that can be termed either ICU rooms or not ICU rooms. And he was in one of those rooms, as I recall. And so, part of the reason that I say FBI investigation here is that since everybody got messy in all of this right away, it has to be shown that the man's medical chart and the description of his acuity starting June 26th is accurate. Or were conflict of interest and liability management, was that already at play? What does it say? Roger overheard people say he could die that weekend. Is that what his chart says? Is that not what his chart says? Was he in ICU? Was he not in ICU? Was he dying? Was he not dying? I mean, these are questions that have to be answered by independent expert outside investigation, and would certainly, and I'm not saying they do, but I'm saying if they did, then that's a very serious criminal matter, falsification of medical records. And these are the questions that need to be investigated, is our point. It's beyond our capacity as a campaign to investigate them, but certainly we believe that the threshold for reasonable and more than reasonable requests of those sorts of investigations has been met and more than met time and again. So he was in that state. He looked like he was dying. He overheard that he was dying. I was told by a physician's assistant that that was one possible outcome of that weekend, not what she really thought was the most probable outcome. The most probable outcome she thought would be a pretty rapid deterioration in his health, ending in nursing care level of home, at some point in the not too distant future. And by the way, look where we're at now. I mean, probably the best Roger's going to recover to out of this infection, which has run rampant both through his damaged body, which wouldn't have been damaged without this mismanaged care, but also as a consequence, this all came about from a urinary tract infection he acquired when he was in the VA nursing home, where he wouldn't have been if his care weren't mismanaged either. So there's lots of ways that connect his current health to his mismanaged care. He did stabilize somewhat, and he was transferred into the Grand Junction VA's on-site nursing home. It's called the Community Living Center. It's also sort of nursing home / hospice ward, another convenient dual designation, just like the ICU room. I mean, I don't know. Roger will tell you and has told me that he didn't know for the 2 months that he was in the CLC whether he were living or dying, or if his liver was improving or not improving. He will tell you that. that he just didn't know if he was living or dying. So again, maybe it's a convenient dual designation that it's the nursing home, but also the community living center. And in that period, his primary provider was a nurse practitioner. I missed something, which is, it's not just that the care went so wrong. That's not just what this story is about. It's that the accountability mechanisms and the safety mechanisms that should have been triggered and that I tried to trigger just sort of fell splat on the floor. So by July 1st, I'd submitted a complaint to the hospital safety office. The pharmacist had submitted a complaint to the hospital safety office about the operation of the hepatitis clinic. I had written this very, very, very detailed and irrefutable, concrete, specific, verifiable course of care document and submitted it to the hospital safety office. I had notified the Office of Inspector General that multiple employees had complained about the operation of this hepatitis program and that this documentation was on the hospital safety office. I had documented all of this in Roger's chart. There's a mechanism within VA medical charts where you can assign notification to all sorts of different people, so they have to see it when they open up their computer. And I'd done that with chief of staff, chief of medicine, chief of mental health, all these different doctors. And so what happens on July 1st is the liver specialist returns, and he's just put back in care of this patient. And I have a big problem with that. I have a huge problem with that. Anybody who came back from a vacation or whatever and saw that their patient had almost died and that this situation had blown up. I mean, it's not every day that people are doing this kind of stuff. It's very rare, blown up with OIG complaints and hospital safety office complaints. Any human being on the planet is going to be terrified of lawsuits and their job and those sorts of things. And so that's where you have these conflict of interest considerations. And when we say it's unethical, some of the things that went on with Roger, it's not just about the poor health care. It's about the decision to return an individual, a patient, to a doctor about whom all of these very serious and substantive concerns had arisen in the preceding days. It doesn't make sense. If you're a pilot and the plane crashes, no matter whose fault it is, if you're an engineer and the train runs off the track, if you're a captain of a ship and it runs aground, that's not the only person who gets to answer what went wrong here, And that's been the VA's approach, basically. It would be sort of like a Greyhound bus crashing along the street, havoc and wreckage, and then the management of the Greyhound bus company coming along and saying to the driver, "What happened here?" "Oh, it wasn't my fault." "Oh, okay, off you go." I mean, that's about what it amounts to. And of course, that's not how the world's supposed to operate. So in the nursing home, Roger was under the intermittent care of the same liver specialist who was implicated in his mismanaged care. As his primary provider was a nurse practitioner, and he recalls and believes that he saw a physician over a 2-month period either once or 0 times.
So what happened to you when you filed this course of care document and you complained? Well, you kind of first blew the whistle.
Well, blow the whistle. I think I said to I said to someone recently, I didn't set out to be a whistleblower, and she said, "Well, no one ever does," and maybe that's true. It probably is true. My intent was to trigger the self-corrective and safety mechanisms of the VA that are supposed to exist when problems correct. I mean, what's the big deal? Something went wrong. What's the big deal with saying, yeah, something went wrong. Let's look at it. Let's fix it. This is what we hear about at a national level, ad nauseum. Accountability and transparency. Transparency and accountability. Accountability and transparency. You know, I mean, it's easy to say the words, but where's the action? And it's so sort of, it's just sort of so stupidly predictable that instead of just saying, yeah, something went wrong, let's look at it, let's fix it, it's like, nothing went wrong. You know, it's so stupid. It's so unnecessary. Why? You know, why? So anyhow, it's not easy to describe what happened between July 1st and July 7th. I resigned on July 7th. I'll be embarrassed and regret that fact the rest of my life. I say and I mean, it's the truth. It never, ever, ever occurred to me that the massive documentation I had done in this man's chart, my complaints to all levels of hospital supervisory structure, multiple complaints to the safety office, the writing and submission of the course of care document, and my complaint to the OIG, it never occurred to me that nothing would happen, that it wouldn't be fixed. So, in retrospect, I abandoned my client in that circumstance, and it's a humbling and embarrassing thing to admit. I've obviously not abandoned him subsequently, but I did on July 7th. And why did I do that? You know, why did I leave? I left because I was exhausted, disgusted, because I was planning on leaving that job at the end of August already. I'd already announced that I was leaving. It was a 2-year funded, so I didn't even have to announce it. It was just ending, and I wanted to move to Denver. And the response that I had to everything I'd done between June 26th and July 1st by my immediate supervisor and by her supervisor was so sort of, just apathetic and slightly hostile. You know, there was talk about maybe Mr. Holmes needs to have a different social worker, and maybe we need to cool this fire, meaning me. But even more than that, just kind of like, what's the big deal? You know, just what's the big deal? I was not willing to be under their supervision again for another single day of work, is what it kind of came down to on July 7th. And that's embarrassing, because then that's about me and ego. And I said in the KG&U thing, there's definitely something in it of stomping one's foot one last time, and that sense of, you know, and slamming the door behind you and just sort of thinking that that's going to make people get, I don't know. But at the same time, my resignation also, the way I document it, was also about, you know, an attempt to sort of draw attention to Mr. Holmes' care. So it wasn't the right decision, but at the same time, I don't lie awake at night beating myself up. It was what it was, and the fact that none of those actions that I did produced any result, it's still a little hard to believe.
So you are still his social worker. You still, he's still your client. Can you talk about the ethics around that and the decision to stick with him?
I don't know if I'm still his social worker. I say I'm his social worker advocate.
Okay.
You know, I'm not serving Roger necessarily in a capacity as a professional social worker. I'm obviously not charging Roger anything. This is, I guess, a point very obvious to me, but bears stating. So I'm a member of the National Association of Social Workers. You know, one of the great services that organization or body offers is that they offer phone consultations with their director of ethics, and you can call in and say, this is what's going on, and this is what I'm thinking about, and you know what, and then have a discussion with that individual, guided by the NSAW, National Association of Social Workers, Code of Ethics, which is a beautiful document. And I think to this day, so I had 2 of those ethical consultations subsequent to my resignation. Once I learned that Roger still needed a lot of help and advocacy, because in the NSAW Code of Ethics talks about the fact that an important ethical principle is called dual relationship. So if I leave a job as a professional social worker and I've served a client, I'm not just supposed to pick up the phone one day because I'm bored and lonely and call him and see if you want to go out for a pizza and a beer. I mean, that's establishing a dual relationship. Dual relationships can be concurrent. Like, I'm not supposed to hire someone to fix my car if they're also, my client, unless I live in like a really small town and it's the only mechanic. I mean, the NSAW Code of Ethics is really flexible. There's no absolutes. But dual relationship also works sequentially. So I'm not supposed to, again, call somebody up that I've worked with or for professionally and say, let's go get a pizza. So in coming back to Roger's aid, I am violating that dual relationship sort of concept. But I say concept because not rule. Because the NSAW Code of Ethics is all about ideas and hierarchy ideas and uncertainty. And this and this and this and this should all be great. But sometimes this is in conflict with this, or this piece is in conflict with this piece. And then you have to figure out maybe which piece is better and figure out, which is more important. And so the first thing I'm saying is my actions are not endorsed by the NSAW. They didn't say, Chris, this is the right thing to do. My point is that in discussing them, it's very thoughtful, and it's a very important principle in social work to seek outside consultation, which I've done. And then there's all this other stuff in the NSAW Code of Ethics about not allowing organizational rules or policies to supersede core social work values. And certainly Roger's mistreatment and powerlessness and voicelessness and helplessness are the core social work values that I'm supposed to be pursuing. Now, if there was somebody else to do it, then it would be wrong for me to do it in some ways. But the last thing I'll say about this, and then I'll be quiet on this because I go on and on about it, is that there's also this idea in social work that you have multiple clients. Like the VA is my client, and they're also my employer. And then Roger and the veteran, each veteran that I've served is my client. And that 99.9% of the time I've been fortunate enough that the interests of my clients have been aligned. But obviously in this case they became grossly out of alignment and in conflict. And so then it's about which of my clients do I serve? And of course that was a very easy decision. So so that's how I believe it's ethical to be serving Mr. Holmes. That's my determination, and it certainly resonates with my heart and soul. And even if there was some mechanism by which I would be banned forever from being a social worker because I'd broken some little rule over here, which is not at all the way that the NSAW Code of Ethics is written or the approach of social worker. But even if it was, it wouldn't matter, because I know it's right. It's right. How could I abandon him? If I weren't doing this, and I'm not some saint, I think the only reason I'm doing it in some levels is because there's nobody else. There's nobody else.
So take us through, you quit, you left the VA, you stayed with Roger. How have you stayed with Roger? Bring us up to the Veterans Day report, and then we can go from there. But how have you stayed with Roger?
Well, it came to my attention through Roger's very good friend. And so much of this story is about being in a small town, because it's hard to say how it would have played out in Denver or something like that. But in Grand Junction, you can't help but bump into people and just sort of hear what's going on. And I'm not saying that it was totally by accident. I mean, I knew as the nature of living in Grand Junction, and knew that because I did bump into Roger's friends in the grocery store, I always knew that I'd be able to kind of keep up to speed on what was going on with him. So it's not like it was just this happenstance. I mean, in a way, that may have played into my decision to resign on July 7th, because I just knew that I would still know what was going on. And of course, I'd hear about all these dramatic things that had happened about the OIG and the safety office that, didn't. So, it wasn't any time at all before it came to my attention, just through Roger's friends, that that he'd been warehoused in the nursing home, that he didn't have a doctor, that nobody was taking accountability, that he'd been returned to this same doctor, that all these horrible things that I'd never envisioned were happening. So it was very challenging to serve Roger when he was still in the CLC, because I did not feel comfortable going back into the VA hospital. But I did keep tabs on what was going on through his friends, and was sure that he did have some advocates, some connections that I have in the community were helping with him with some of his earliest sort of next level complaints to folks like elected representatives, or following up. I knew that he was getting a certain level of advocacy from some contacts I had in the community, but it was a huge. And of course, I was in contact with Roger's good friend. So I guess you could say I was monitoring what was going on, and he was still too sick really to participate in a lot of this, because it's so knowledge and data intensive. And then the other thing is, his family, his son and daughter, they're in Salt Lake, and that's, I think, one of the powerful aspects of Roger's story, is so many of our older veterans, particularly those who may have struggled with addictions or mental illness or homelessness, they're either geographically or isolated from family, or for emotional, family history reasons, because of the long and bumpy past. And so, a lot of these guys, they don't have anybody else, and so it raises these questions about who does advocate for them in a healthcare system when things go wrong, if they don't have family, like so many of our older veterans don't. It's a big concern, and it's been one of the biggest disappointments of this circumstance, because my answer to that should be, the Hospital Safety Office and the Office of Patient Advocacy, and ultimately the OIG, and none of those things happened. So I guess you could say I was monitoring through friends and connections what was going on a little bit with Roger's care through July and August. And then when he was released to home from the hospital on September 19th, after spending 2.5 months there, he still required 3 times a week in-home nursing care, because he was still too brain damaged to manage his own medications. I immediately contacted him and said, Roger, let's get to work. We've got this great kernel of a report, being the emails that I kept and the course of care document, but let's build this comprehensive report around it that really spells out in sort of unmistakable terms what the issues are here. And that'll give us a platform then to go to media, go to public representatives. Because what I found is that without being able to collaborate with Roger for those 2 months, and without being able to generate a report like that, is that I had all this documentation, but nobody understood what the heck I was talking about. I mean, it's like so. It just confused them. So to have a nice, concise package that we could show and distribute has really served us as the foundation for everything that's come afterwards.
And that's the report you filed on Veterans Day?
Correct. We distributed it to veterans groups, public officials, OIG, and media, and on our website. When you say get to work, what were you trying to achieve? I think of first of all, let's have accountability and transparency. Let's see it. So we want an OIG, Office of Inspector General investigation. For those that aren't familiar with what an OIG is, every federal agency has associated with an Inspector General's office. So there's the VA Office of Inspector General. And their job is oversight, investigation of fraud, lack of safety, abuses, things like that. Now, one of the core dynamics of any OIG office is they get innumerably more complaints than they can actually follow through on. So it's not just like you say to the OIG, hey, this thing's all messed up, and they come running with their, investigative powers. They don't. Most complaints don't get investigated, and thus the need for this public awareness and public pressure campaign. So the other reason that we really want to, that we really want this FBI investigation as well is because there's been some concerns about the effectiveness and sometimes the motivation of the OIG, the Office of Inspector General, coming out of the Phoenix circumstance and a lot of the criticism of the report that came out of Phoenix. I have mixed feelings about that. I think you can see it from a variety of perspectives, but certainly the more people doing the investigation in this circumstance, the better. So we want an investigation to find out exactly what happened here and answers. What we know from a certain level all the things that went wrong. It's self-apparent, but we don't have investigative powers. I mean, the OIG has subpoena powers. They can take a doctor and they can make them sit down and they can make them answer questions, and they bring in things like expert forensic hepatologists to look at what was the medical decision that was made on June 25th with consultation from a family practice doctor at St. Mary's, and did that fall within industry standards or not industry standards? How close was Roger to dying? How can one account? What was the structure and funding of this hepatitis C program? Where this was there's so many questions. The questions never end. Frankly, they end, but there are many, and it takes somebody with investigative power and subpoena power ultimately to come at some of those answers. One of the things I haven't even addressed is it's very challenging to find an attorney to pursue a lawsuit against the VA. It's all governed under an entirely different body of laws called Federal Tort Claims Act. It's a whole different specialty, and cases are very difficult to win. The information is very difficult to get at. It's nothing like the private sector. People think that, say what you will about medical malpractice attorneys. They do serve as a check and balance in our society to help ensure safety and quality health care. Of course, it doesn't always work, but it is conceptually a check and balance. There's no such fear. There's no such check and balance within the VA system. So that's another reason we need this outside investigative entity, is because that check and balance of medical malpractice looks vastly different within the VA system. Another goal of the campaign was to rally support around Roger and just make him feel loved and cared for. I mean, he was a sick, sad, brain-damaged, lonely, abused, voiceless man sitting alone in his dark apartment, hardly able to get outside at all, and really only able to function for 4 or 5 hours a day. And it's just heartbreaking. And so one of the gratifying things about publicizing his message has been to see people come to him and join with him. And it's been really fun to get him a computer and get him online, and he's starting to learn how to email and use Facebook, and Chris, I'm practicing really hard 2 hours a day to learn Facebook and stuff. So to be connected, on the internet is an incredibly empowering experience. I never had experienced it in the way that I've seen it with Roger. And Jenny, what's our other goal?
Getting a doctor.
Oh yeah. And of course, number one is to get him to an appropriate liver specialist, gastroenterologist or a hepatologist. And so we had a fundraising campaign. We're having it. It's been enormously successful. We've already collected $2,500. And we were just on the cusp of getting him to that step when the setback has happened. So the sad reality is that goal and those monies may never able to be spent for the purposes for which they were intended. The good news is I've been enormously impressed with the quality of care that he's getting at St. Mary's Hospital in Grand Junction. And I'm not Mr. Bag on VA guy. I'm just not. But I'd forgotten what a real hospital looks like. And so yeah, those are some of the goals.
So the VA kind of didn't want to treat Roger so much.
Roger's requested repeatedly from through July and August, and even more specifically in September, October, and early November for a liver specialist. An appropriate liver specialist, not already involved in his botched course of care. Someone who doesn't have that conflict of interest or liability management considerations as well. And those requests have been repeatedly denied. He's been told that primary care, being seen in his primary care clinic, is an appropriate place to be treated and a way to be treated moving forward. And in fact, just as recently as a month ago, he got a call from the patient advocate, or he called the patient advocate requesting once again to see a liver specialist, and the patient advocate said, well, we'll see what we can do, and haven't heard back. So there's been no movement towards having him seen by an appropriate liver specialist.
So if Roger doesn't make it, what happens next?
A lot of heartbreak and grieving, and probably even more determination to push forward, both for retrospective justice for him and his family, but even much more so this idea that Roger was always the proponent of, which is that this is about much more than just him. That by helping me, we're helping every veteran getting services in Grand Junction, Western Slope, and beyond. Because A, we need these accountability and transparency mechanisms that are supposed to function within the VA to function. They have to function. So that's one reason. And B, because bringing these shortcomings to light spurs improvements that help everybody else. And there's no clearer example of that than, again, the fact that Grand Junction VA is no longer offering or providing hepatitis C treatment. They understand now that they don't have the resources to do that. And that's a change that came about from Roger's campaign, and that helps innumerable others not befall the same sort of tragedy. So we will persevere no matter what happens. There would be no better tribute to Roger than that.
So you put your professional life and your personal life on hold, working pretty much full-time on this campaign since September. What does he mean to you, and what does this campaign mean to you?
Well, the first thing I always say is I had a discussion with myself, and it went something like this. Roger is the most deserving client I've ever had because of who he is and what he gives back. I am single. I don't have any kids. And I have money from my father's death in 2012 that I just inherited. So I have some money in the bank. So I said, if I can't do this, I can't imagine being in this position and having a mortgage and having kids and school and all these. It's great to get on your high horse in terms of ethics and doing the right thing, but oftentimes there's so many things that get in the way of that. Real things, real life things, and important things like kids and money. So I'm incredibly well positioned and fortunate to be able to do this with a sort of a minimum of personal sacrifice. And I sort of said, if I can't do this, given the fact that I got some money and I don't have some of these other considerations, and if I can't do it from Roger, my goodness, who can? So Yeah, it's been exhausting. It's been grueling. It's been wrenching and all those sort of things. And at the same time, I'm not. I didn't have to risk some of those other things that people risk sometimes in these circumstances, or give up some of those other things. What Roger means to me. We'd probably have to sit here for a couple more hours to talk about what Roger means to me, but he's a beautiful human being. He's a beautiful man, and I certainly could never live with myself if I did not attempt to serve him to the end of my days, to get as close to justice and fairness for him as we'll be able to get, and who knows what that will be.
So when we chose to give you this award, and this is our first time we've done this, it was really because you were shedding light on something that was happening in the darkness, that nobody was really covering that hospital, nobody was covering his case, nobody was speaking out. And I said this on the radio the other day, you're not just a whistleblower, you're a megaphone. You've been a megaphone for Roger. And when I had it in my mind, and I was kind of emailing Roger, and I thought maybe he'd be here today, or at least on Skype, it didn't really occur to me that we're also giving you this award on his behalf.
Yeah, absolutely.
Because he can't be here to say what I imagine he would say, which is thank you. So, to say thank you. Blumenstein, Righteous Whistleblower, the Colorado Indie, December 2014. Congratulations.
Is it? Now, is this functional art, Susan?
I don't think so. You're going to have to get your own whistle.
Thank you.
Yeah, I want to say this, is that we haven't covered the story journalistically. We're not reporting on it. We like whistleblowers. You make our jobs easier, and you make our world better, and I just want to say we're proud of you.
Thank you. I can intellectually acknowledge what you're saying. It's hard to sort of internalize those sorts of things about oneself. Like I said, it's been a rocky road. I've made lots of mistakes. I never set out to be a whistleblower, but we've had this discussion, and you've made me see that it is important, particularly in this era of shrinking media and shrinking local media and shrinking local substantive news coverage, that people are willing to, who work inside of agencies or corporations that perhaps aren't doing the best they can to speak out as challenging as it can be. So I sort of, it's hard to sort of accept it, and at the same time I do accept it on those grounds. And most of all, of course, this is for Roger, and it's all about Roger, and it always has been and it always will be.